Diabetes is a subject that needs a lot of discussion in our physical therapy setting because a large number of our patient population are affected by diabetes. So we have to know about it. We have to know what are the contraindications for treatment. We have to know about the process, and we can help people manage their diabetes. And exercise can be a big part of that, and we can help them with that. So first we'll talk about everything. Let's just start into it. So diabetes mellitus is what we're talking about. There's also diabetes insipidus, which is a defect or a deficiency of antidiuretic hormone, and we'll talk about that in the next section. But diabetes mellitus is basically inadequate insulin effects in receptor tissues. So it can be caused either by a deficit of insulin secretion in the case of type 1 diabetes, or the production of insulin antagonists. Diabetes results in abnormal carbohydrate, protein, and fat metabolism. Some tissues can transport glucose through their cell walls in the absence of insulin. So when you think about insulin, the blood sugar is floating around. It got metabolized through the small intestine. It got into the bloodstream, and it's floating around. And now it needs the insulin to hold its hand and walk it through the door to the cell, basically, if you want to think of it like that. So the insulin is blood sugar's key for transporting glucose into the cell. It's your pass key, basically. So if you don't have it, the glucose isn't going to get into the cell, and the glucose is a primary source of energy for the cell. But in the central nervous system, the kidney, the myocardium, the gut, and skeletal muscle, their needs of glucose transport can happen in the absence of insulin. Skeletal muscle can partially meet tissue needs without insulin. That's one of the reasons why exercise acts like insulin in metabolizing blood sugar. Because if your skeletal muscle is working harder, you can help metabolize that glucose. So in type 1 diabetes, it's an autoimmune destruction of the beta cells in the pancreas. The beta cells are the ones that create the insulin. Insulin replacement is absolutely required. Usually the onset is acute in children or adolescents. It's not linked to obesity like type 2 is, and genetic factors may play a role. They don't know the exact genetic factors that determine whether you're going to get type 1 diabetes, but they definitely play a role. So a lot of people with type 1 diabetes end up getting insulin pumps, which really helps them regulate. So it's an implanted pump that helps them regulate their insulin in their body, and that's a really cool adaptation of insulin therapy that really makes a difference in people's lives. There's also a lady that I worked with last year who had an insulin sensing dog. She was a service dog that was trained specifically to sense whether the patient's insulin levels were low or high. If the dog detected a low or high insulin level, she would alert the person, and then the person would say high or low. The dog had one thing that it did for high and the other thing that it did for low. I think that's absolutely amazing. Number one, the dog can detect that, and number two, that they can be trained to do that. And she was the greatest little dog. She was an English lab, so she was like a regular black lab except maybe 3/4 of the size, and that was her job, is to monitor her mom's insulin level. So, I mean, what an awesome use for a service dog. Type 2 diabetes is the non-insulin dependent type. Often oral hypoglycemic medication is used. It's caused by either a decreased production of insulin or increased resistance by body cells to insulin. So that insulin resistance is a big part of type 2. The onset is slow and insidious, and it's usually in people older than 50 years, although obesity can play a factor in people younger than 50. It is associated with obesity, and it's a component of metabolic syndrome. There's unfortunately increasing incidence in teens and young adults. Metabolic syndrome involves high triglyceride levels, high blood sugar levels, and high cholesterol levels. And they're all tied in, associated with obesity. So, type 2 diabetes can be avoided. Type 1, you're kind of stuck with it. So it's a good disease to avoid because this is a terrible disease. We will talk about some of the complications of diabetes, and it can wreak havoc on you. Basically, it can wreak havoc on your entire body. So the general manifestations, whether you have type 1 or type 2, the insulin deficit results in decreased transport of glucose into many cells, which causes the symptoms of polyphagia and fatigue. Polyphagia meaning you want to eat all the time because your cells aren't getting adequate nutrition, adequate glucose, and so you feel like you have to eat all the time. And you're fatigued because your cells aren't getting adequate glucose. The blood glucose levels rise, which is called hyperglycemia. They rise because the glucose isn't getting escorted into the cells because you don't have enough insulin, or the cells are resisting the insulin's effect. You also have excess glucose in your urine, glucosuria. Dehydration results from hyperosmolar filtrate, meaning you excrete more water with the glucose. Polyuria, which means you have to pee all the time. Polydipsia, which means you're thirsty all the time. So polyphagia, polyuria, polydipsia, those are ones that a lot of times you show up. This is a weird thing, but I'm going to say it anyway. We've had 2 different cats with diabetes. Both of them were strays that we adopted. Both of them were overweight once they got to a place where they had unlimited food. And they both developed diabetes. And the first symptom with both of them was polydipsia. They drank water like I've never seen cats drink water. Usually cats will just lightly sip a little water here and there. These guys would knock down bowls and bowls of water. And that was our first sign, like, oh, we got to go get these guys checked. It's pretty easy to manage a cat's diet and manage their insulin level, though, because you have complete control of what they eat, as long as they don't go outside and eat somebody else's food. Anyway, it can happen in cats too, but polydipsia, that's one of the hallmark signs. The diagnostic tests that they do fasting blood glucose level, glucose tolerance test, and glycosylated hemoglobin test. So that can help detect clinical and subclinical diabetes. So where subclinical is where you have the elevated blood sugar levels, but you're not having the symptoms yet. And it can monitor glucose levels over several months. So the diagnosis of diabetes is based on the presence of any one of the following 4 factors. So presence of polyuria, polydipsia, weight loss, blurred vision, and random plasma glucose, regardless of when you ate your last meal, so it doesn't necessarily have to be fasting. So a lot of times that is seen in people with type 1 diabetes. Number 2, fasting plasma glucose of greater than 126 milligrams per deciliter. Fasting involves no caloric intake for at least 8 hours. A 2-hour post-load glucose, so what they do with the glucose tolerance test is they give you 75 grams of oral glucose dissolved in water, and then they test you 2 hours later and they see how fast that glucose goes out of your system, how you tolerate it, basically. And number 4, A1C of greater than or equal to 6.5%. So A1C is a It's a hormone that's used as a marker for chronic glycemia and glycemic management. So it's almost a measure of how unstable your blood sugar is. So if you have that higher A1C, it means your blood sugar is fluctuating out of control. So that's how they come up with the diagnosis of diabetes. If you ate a donut and just went and got your blood tested, an hour later, of course your fasting blood glucose is going to be high, but then 2 hours later, how fast did you metabolize that? So the fasting is important, and the glucose tolerance part is important. And then the A1C, it tells how you are over time. So one of the ways they can tell if people are, once they've been diagnosed, if they're controlling their insulin levels, is their A1C. So if their A1C stays low, that means their insulin levels are even. There's not a lot of up and down. If it goes high, it means there's a lot of up and down and it's not under control. So the treatment principles for diabetes, the medical and other treatments, maintenance of blood glucose levels in a normal range helps reduce complications because you're not getting those highs and lows, you're not getting the stress on your system. Diet and exercise. So exercise reduces blood glucose level because skeletal muscles use more glucose and they don't need the insulin to metabolize it. And then diet, controlling your intake, that's important. Oral medication can increase insulin secretion in type 2 diabetes, and it can reduce blood glucose levels. And insulin replacement is necessary in type 1, and it's often used in type 2 as well. So with type 1 diabetes, when catabolism is the breaking down of fats and proteins, so when fats and proteins are broken down, you get excessive amounts of fatty acids and metabolites and ketones in the blood. So ketonuria is when you have an excessive amount of ketones in your urine. It causes decreased serum bicarbonate, it decreases the pH of body fluids, and ketoacids are excreted in the urine. So it's basically decompensated metabolic acidosis. And we learned about that last quarter, right? So the complications are directly related to the duration and extent of abnormal blood glucose levels. So like I was saying, the A1C is kind of measuring how out of control your glucose is. When it's lower, it means it's more in control. So you do not have as many abnormal levels. A lot of times you'll meet people who think that they can eat whatever they want and just adjust their insulin amounts to control their diabetes. Well, they end up getting a lot of highs and lows. So they have more complications because there's more extent of abnormal blood glucose levels and sometimes more duration. So they have to use diet and exercise and insulin and their other oral medications to control it as a whole. So there are different factors that can lead to the fluctuations in serum glucose levels, variations in diet and alcohol use. So you just had a gin and tonic and a donut. Oh, that sounds awful. Anyway, you get what I'm saying. You're not controlling what you're eating. Changes in physical activity. So that's what I was saying, where the nurses would get mad if we would take people to the gym and work them too hard before dinner, because then their blood sugar would drop too low, or before they had their insulin. Infection can change how your glucose levels fluctuate. And vomiting, because that's changing your internal chemistry. Complications can be acute or chronic, and we will talk about some of the acute versus chronic complications. So, acute complications of diabetes are hypoglycemia, also known as insulin shock. It's more common with insulin replacement treatment than it is with the other oral medications. It can occur because of excess oral hypoglycemic drugs. So there's excess insulin in your circulation and a glucose deficit in your blood. It can be life-threatening or cause brain damage if untreated. Strenuous exercise can bring it on because you're using up all that blood glucose. A dosage error can bring it on. Vomiting, again, you're messing with your body chemistry there. And skipping a meal after taking insulin. So you have to coordinate your eating, exercise, and insulin to keep the levels correct. So the signs and symptoms of hypoglycemic shock: disorientation and change in behavior may appear impaired. Anxiety or decreased responsiveness, decreased blood glucose level, decreased blood pressure and increased heart rate, and decreasing level of consciousness. So at that point, you really have to administer glucose right away to prevent brain damage. So I'll tell you my hypoglycemic shock story, or one of them anyway. When I worked in the emergency room in the early 80s, I worked in an emergency room in a small hospital, and a lot of times the highway patrol would bring people in to get blood alcohol levels tested, and there were 2 different blood alcohol levels they would do. So they pulled somebody over, they suspected that they were under the influence of alcohol. They would usually on their way to jail bring them into the emergency room to get their blood drawn, to get their blood alcohol levels tested. So there were 2 different ones. There was a medical blood alcohol that we would do right there in our lab at the hospital, and there was a legal blood alcohol that was a thing that got sealed into a container that got sent to the state lab. And this was in Colorado in the 80s. I don't know how they do it now. So they brought this guy in. He was disoriented and he appeared impaired. He had decreased responsiveness. He was stumbling. He had a hard time getting up onto the gurney. He looked drunk. The guy looked drunk. We all looked at him and we thought to ourselves, yeah, this guy's been drinking. And we saw it all the time. The highway patrol were always bringing in people for blood alcohol levels, and the guy looked drunk. Okay? So, they drew his blood, they sealed up the one that went to the state, and they sent the other ones to the lab. And just to be thorough, the emergency room doctor, and the guy was basically headed to jail. He was going to spend the night in jail, and for DUI. And the doctor, just to be thorough, did a CBC and a metabolic panel, had the lab run those as well as the blood alcohol level. Well, the blood alcohol level came back first before the CBC and the metabolic panel, and it came out as 0. The blood alcohol level, no alcohol in the blood. And so the doctor went and reamed out the lab tech, said, you got to rerun this test. Obviously this guy's been drinking, you blew it, do it again. And in the meantime, the metabolic panel came back and the guy's blood glucose was 58. Very low. Normal is about 100. And so he was in hypoglycemic shock. They right away gave him, they administered some IV glucose. He came around like that. He was talking to us and he was more responsive and everything was normal. And honestly, if the doctor hadn't run that metabolic panel, that guy might have died in jail. They might have taken him to the jail and he might have died. So thank goodness that the doctor was thorough on that, and that he saw that difference. And we all learned our lesson that night, is just because somebody looks impaired doesn't mean they're drunk. And to really look at everything that's going on. So the other thing that the doctor did, besides, save the guy's life, what had happened is, the man had taken his insulin and he got delayed and wasn't able to get home and eat dinner in time. So his blood sugar level dropped way down. And he didn't have a medical alert bracelet, so the doctor gave him a medical alert bracelet, talked to him about how important it is that people know he's diabetic and that sort of thing. And it was a happy ending, because it was the workup was thorough. So it's really interesting that the change in behavior and the disorientation can appear to be something else, but the person could really be in hypoglycemic shock. So another acute complication of diabetes could be diabetic ketoacidosis, which is the opposite. It's high blood glucose levels and insufficient insulin. Hypoglycemic shock or insulin shock is high insulin levels and low blood glucose. So with diabetic ketoacidosis, it most often occurs in insulin-dependent clients. So it's more commonly seen in type 1 diabetes. So it's a result of insufficient insulin in the blood. It's high blood glucose levels. The liver mobilizes lipids to meet cellular needs, and it results in the production of ketoacids, the metabolism of the lipids. It can be initiated by infection or stress. It may result from an error in dosage, infection, or a change in the diet, alcohol intake, or exercise. So just like hypoglycemic shock, diabetic ketoacidosis, which is also sometimes called diabetic coma, is a very serious side effect. Dehydration, it causes dry, rough oral mucosa and thirst and warm, dry skin, rapid, deep respiration, and acetone breath. Sometimes it'll be like almost a fruity smell to the breath, and lethargy and decreased responsiveness. So that the person might not know what's going on because they are out of it, because they're going into ketoacidosis. Metabolic acidosis, which may lead to loss of consciousness, and electrolyte imbalances, which might lead to abdominal cramps, nausea, vomiting, lethargy, and weakness. So again, a very serious acute side effect of diabetes. There's another acute complication that's called HHNK syndrome, which is hyperglycemic, hyperosmolar, non-ketotic syndrome. It occurs in type 2 diabetes. It has an insidious onset, so the diagnosis may be missed. And it often occurs in older clients, and it's assumed to be cognitive impairment. So they say, oh, it's missed because it's assumed to be cognitive impairment. It results in severe dehydration and electrolyte imbalances. So hyperglycemia, extra high blood sugar. Severe dehydration, increased hematocrit because there are more red blood cells than there is fluid in the blood. Loss of turgor, meaning the skin doesn't bounce back when you pinch it. Increased heart rate and respirations. Electrolyte imbalances can result in neurological deficits, muscle weakness, difficulties with speech, and abnormal reflexes. Well, all of those things, they sound like symptoms of other things too, don't they? So that's why it's often misdiagnosed, because it could be anything. And so they have to do a thorough workup. Again, like my hypoglycemic shock story, if the doctor hadn't done a thorough workup, that could have been a life-ending event for the man. But luckily, the ER doc knew what he was doing, and he did a thorough workup. So somebody with diabetes, they can have these acute complications, and they have to get quick, accurate treatment in order to survive. There are also chronic complications of diabetes. Vascular problems, including increased incidence of atherosclerosis and changes in small and large arteries. Microangiopathy, which is changes in microcirculation, obstruction or rupture of small capillaries and arteries, which can result in tissue necrosis and loss of function. Neuropathy and loss of sensation. You'll see a lot of people in PT who have peripheral neuropathy as a result of diabetes or from other reasons. And that's going to affect their balance and their proprioception. Retinopathy, which can cause blindness. It's the leading cause of blindness, actually. And chronic renal failure because of degeneration of the glomerulus of the kidney. So these are all chronic complications of diabetes. Diabetes is a terrible disease. It wreaks havoc on your body. Macroangiopathy, which affects the large arteries, it's a result of abnormal lipid levels because of that metabolic syndrome. High incidence of heart attacks, strokes, and peripheral vascular disease. Unhealing ulcers or slow healing ulcers on the feet and legs, and frequent infections and gangrenous ulcers. Diabetes is also one of the leading causes of amputation because of this macroangiopathy. It's also one of the leading causes of peripheral neuropathy. It's a common complication caused by ischemia in the microcirculation to the peripheral nerves. So you get impaired sensation, numbness, tingling, weakness, and muscle wasting because the neuromuscular junction is affected. So this is a neuropathic ulcer. One of the things we can educate our patients about is frequently inspecting their feet, because if you have neuropathy, you can't feel if something is wrong down there. So inspecting your feet with a mirror or having somebody else look at them is a really good thing to do, because you can get help with something soon instead of waiting till it gets to the point of amputation. Infections are common and often more severe in diabetics because you have more food for pathogens in your bloodstream, basically. Infections in the feet and the legs are caused by vascular and neurological impairment. Fungal infections are common, caused by candida, because, again, there's more fuel for the pathogens. Urinary tract infections are more common, dental caries or cavities, and gingivitis and peritonitis, all for the same reasons, excess sugar in the bloodstream. Cataracts, it's opacity in the lens of the eye. It's related to abnormal metabolism of glucose, so it's pretty common in everybody, but it's more common in people with diabetes, and it's treated surgically. During pregnancy, complications in both the mother and the fetus may occur. It can increased incidence of miscarriage or spontaneous abortion. Infants born to diabetic mothers are increased in size and weight for their date, and a lot of them experience hypoglycemia in the first hours postnatally, so they have to be carefully monitored. There is a type of diabetes associated with pregnancy that's called gestational diabetes, where the sugar metabolism, glucose metabolism is affected because of the pregnancy, and usually once and with all the potential complications for the baby, usually once the pregnancy is over, the gestational diabetes goes away, but it's still, the complications can happen because of that. So regardless of the type of diabetes, type 1 or type 2, regular physical activity is important for overall health and wellness. With type 1, it's really important to balance insulin doses with food intake and activity, even when performing just your activities of daily living. People with type 1 diabetes should be encouraged to plan ahead and know their body's typical blood glucose response to exercise so they can keep their blood glucose from going too low or too high. A lot of people are diagnosed with type 1 diabetes when they are kids or teenagers, and so that's hard. One of my friends, her 18-year-old son was diagnosed with type 1 diabetes when he was 16, and one of the hard things for him was go out with your friends, and you're going to have, pizza and soda, and just not being able to do that the same way, not like feeling like the weirdo kid because you're ordering a diet soda, or you're not getting the pizza, you're getting something else. It's just sort of like that, not being part of the crowd. That was hard for him. He got over it, and he learned to manage his diabetes really well. And he's an active kid. He has been ever since he was little, playing football and judo, and her kids dance in a Ukrainian dance troupe and all this other stuff. So he's active, and that's one of the things, is he really had to learn how to plan ahead and always bring snacks with him to make sure that his blood sugar didn't go too low or too high. I had a student several years ago who was a type 1 diabetic, and he eventually got an insulin pump implanted, which was great for him. But he said the difficult thing to manage was having his blood sugar right for the right situation. So he said, like, for an exam, in order to maintain his focus, he needed his blood sugar to be a little bit higher. For a situation like where you're in lab for several hours, he had to eat several times during the lab to make sure his blood sugar didn't go too low. But if it got too high, that was a problem too. So school was a challenge for him, having to plan that out and figure out how it was going to work. So for type 2 diabetes, the American Diabetes Association recommends both aerobic and strength training. Aerobic exercise helps body use insulin better. It strengthens the heart and bones, it relieves stress, it improves blood circulation, and it reduces the risk for heart disease and those other complications by lowering blood glucose and blood pressure and improving cholesterol levels. So the American Diabetes Association recommends 30 minutes of moderate to vigorous aerobic exercise at least 5 days a week, or a total of 150 minutes per week. For strength training, also called resistance training, it makes the body more sensitive to insulin, meaning it can work better, and it can help lower blood glucose in that way. And it helps to maintain and build strong muscles and bones, reducing the risk for osteoporosis and bone fractures. So the American Diabetes Association recommends doing some type of strength training at least 2 times per week in addition to aerobic activity. So this is something that we can educate our patients about, and we can help them come up with a program that works for them. So for physical therapy in general, and a lot of times in an inpatient setting is where this really comes into effect, but glycemic control for patients with type 1 or type 2 can be altered significantly with the onset of new illnesses, particularly systemic infections, because new processes in the body require added glucose metabolism. It's important for us to carefully monitor the patient's blood glucose levels during therapeutic interventions, because the symptoms of diabetes can be exacerbated in a patient with significant comorbidities. So if they've got a lot going on, plus they've got diabetes, that can really change their reaction to things that we do with them. So people with diabetes, they have a wide range of their individual normals. Like I was talking about the guy who said he functioned better with his blood sugar a little bit higher when he was taking an exam, but it needed to be a little bit lower when he was doing other things. So each person kind of has to establish their tolerable high or low value. And it's important for the PT to sort of figure that out in the initial evaluation to determine the parameters of what we can do in physical therapy. So people with poor glycemic control can have wide fluctuations in blood sugar levels on a daily basis. So it's really important to always verify their blood sugar level before they do physical therapy. So if you have someone in an inpatient setting, you can coordinate with nursing to get that done. If you're in an outpatient setting, you can talk to the patient about checking their blood sugar level before they come in. So a pre-exercise glucose level less than 100 milligrams per deciliter may require added carbohydrate ingestion before starting the activity. If the patient feels well and there is an absence of ketosis, which can be tested with little urine strips, then monitored exercise can proceed. So patients who were following a regular exercise program before they were admitted to the hospital need education about how to modify their exercise during their hospitalization and once they're discharged. So that is something that we will be able to educate them on. So modifying their exercise parameters is, of course, going to depend on what else is going on with them. So hypoglycemia can happen during exercise or up to 24 hours after exercise because of an ability to regulate insulin levels. So to help prevent hypoglycemia, the patient should consume extra carbohydrates before and during exercise. So the recommendation from the ADA is 10 grams of carbohydrates per 30 minutes of activity. Circulation of insulin that's injected into an exercising limb is enhanced as a result of increased blood flow and increased temperature. So insulin injection into an exercising limb can lead to hypoglycemia because the insulin is processed faster, basically. So in order to help prevent this, you can have them inject the insulin into their abdomen, just to normalize their insulin circulation. So insulin is necessary to modulate lipolysis and hepatic glucose production during exercise. So performing exercise without adequate insulin can lead to hyperglycemia and ketoacidosis, also a serious complication. Coordinating physical therapy sessions with meals and insulin injections can help optimize exercise tolerance. So a lot of times if you're working with someone in an outpatient setting, they are managing that, or you are coordinating with them to manage that. When you're in an inpatient setting, you have to coordinate with other members of the healthcare team to optimize that. Sometimes when you're in an inpatient setting, exercise tolerance can make the difference between someone being able to get up and go to the bathroom by themselves versus not being able to do it. So they're pretty critical, essential ADLs. So keeping glucose sources such as graham crackers close by is helpful in case of hypoglycemia. So your PT clinic should have a diabetic rescue kit, and in our clinic we do have one of those at the with our first aid kit. We have glucose packets and graham crackers and peanut butter, just in case somebody needs it for hypoglycemia. And you have to monitor your patient when they're exercising to make sure that you're not seeing any signs of hypoglycemia.